to this, we see each other, right?
Yes.
Okay, very good. Perfect.
So otherwise also we'll be able to see each other because it gives that option of our faces being visible alongside your presentation.
Excellent. Very good.
So, Dr. Javed, you can start. It is 9 o'clock.
Okay. Welcome all delegates and participants. Good morning, Dr. Francine. We are so thankful to you. You have joined us and you will teach us today, about integrities of oscillometry. I'll not waste time because this is going to be a very important session. I'll straightforward invite our chairperson, Dr. Sanjeev Singh Rawat, for some opening remarks.
Thank you, Dr. Javed, and welcome to all the delegates who have joined today evening for this very important session. Good morning, Dr. Francine, for joining this session, and actually impulse oscillometry in India now it is coming in a big way, and a lot of centers are started using this particular modality. But still, we don't have standard, we don't have cut-off values in India, and there are a lot of confusion regarding the use of this particular modality. So I'm sure your lecture would clear this age. Your lecture will give some important inputs so that people who are using this modality in India, they'll be able to use it more confidently. So thank you very much, and over to Dr. Javed to please start the session, please.
So I'll request Dr. Kamal, who is our moderator for this session, to formally open the session for this talk.
Thank you, Dr. Javed. Thanks a lot. And good evening, all. It's good morning to Dr. Francine. So we have a very interesting session lined up. Dr. Francine has done a lot of work in asthma and these PFTs as such. So we have a very learned speaker with today. I will request the audience to please put your questions in the chat box so that we will frame them accordingly, and I'll put them to the speaker. So without wasting more time, I will straight away request Dr. Francine to please start with her presentation. Professor Francine.
Thank you very much. So I'm delighted to be speaking to you in distance. It's fantastic that we can do that on oscillometry in pediatric asthma. I've been using that for over 25 years. And I want to review with you the clinical utility, the positioning of this approach, and the future outlooks. Here are my disclosures. So I serve in a number of consultancy board. I just want to highlight that Thoracis is sponsoring this presentation. But I've worked with other oscillometry devices. So the objective is to understand the lung properties measured by oscillometry, to recognize the psychometric properties of oscillometry, and to review together the scientific evidence for the use of oscillometry in the diagnosis, in the risk assessment, and the monitoring of children with asthma. And I will close by summarizing the challenges and the facilitators to the uptake of oscillometry in clinical practice. So I wanted to start with this because that's a big concern. So this is a birth cohort of patients that were received a pulmonary function test at 1 month, and then they were followed all the way up to 7 years. And at 7 years, they were identified as being asthmatic or not. And you see the lung function of asthmatics is generally lower than that of control. But the airflow deficit was already present at birth. At least 40% of the airflow deficit that was seen at 7 years was already there at birth. So probably small gestational age, maternal smoking, etc. But 60% occurred in the interim, and that's where we can intervene. So the preschool years are a window of opportunity to maximize lung growth. And that's how I went into using oscillometry. The other thing that needs to be told is that within 2 years of onset of symptoms in preschool wheeze, there is airway remodeling with thickening of the reticular basal membrane in patients that had confirmed wheeze compared to controls. So oscillometry is an objective measure of lung function. It's feasible in preschoolers as well as in school-age children. It is feasible, it is reproducible, it is sensitive to change. With regards to data acquisition of oscillometry, the child needs to be seated with a nose clip in place. have the head in a neutral position with the chin a little tilted at 15 degrees upwards. We need to have cheek and chin support, and we're looking for at least 3 up to 5 acceptable measurements with a reproducibility coefficient, a coefficient of variation of 15% or less for resistance. And we are reporting the average values. So it's easy, it's effort independent. The child just needs to have a good seal around the mouthpiece. So let's cover the lung properties. So what happens here? So the device generates pressure oscillation that we call wave at different frequencies measured in hertz. Some device trigger is square waves. This is what we call the impulse oscillometry, or IOS. And others generate sinusoidal waves. The prior terminology was force oscillation technique, or FOT, that you will see in publication. We moved away from that terminology because people believe that force oscillation meant that there was a force expiratory maneuver where there is not. So the preferred terminology for all these devices is oscillometry, and that's what I'm going to use from now on. So what is measured by this device is the impedance, and it's measured by the change in pressure flow. What is reported is and calculated is from the impedance being decomposed into resistance and reactance. And each of these measurements are reported as a function of the oscillatory frequency. For example, you will see RRS 5, which means resistance of the respiratory system at 5 hertz, or sometimes the abbreviation of R5, resistance at 5 hertz. So what happens? So there's a oscillation that goes into the lung, and what we measure is the difference when it goes out. So a little bit like the echo. So it's the change in pressure and flow. This impedance is, as I said, decomposed into resistance and reactance. I'll tell you what that means. And varies. It's oscillation. So
I think
in
we have
the central airway.
okay. I think we lost
Do you hear?
your voice. Yes, in between there was a break of around 5 seconds, but as of now, we can hear you well.
Okay. So what I was saying is that the slow oscillation.
Madam, we can't hear you.
You cannot hear me.
There's a problem in your audio, ma'am.
But it is again, you are again audible. So there is a break of around 5-10 seconds. But as of now,
Okay.
again, you are very audible.
Okay, let me know if it happens again. Okay.
You can start with the previous slide, madam. You can start with the previous slide. You can start with the previous slide.
Well, I wonder whether the previous slide is a problem. So let me move with this one. So
Okay. Right,
yeah.
right.
So here, so what you will see in terms of curve is you will see the resistance either measured in centimeter of water per liter per second or in kilopascal per liter per second over the frequency. And so because R5 covers all the way to the small airways, so there's a higher resistance. And as the oscillation frequency increase, the resistance decrease. And same thing for the reactance. So resistance of 5 measures the entire respiratory system. The ones around 1920 measure more the proximal airways. In the past, we were only looking at R5 and R20, and we realized that we were missing out on many. So for example, if you subtract R5 to 20, you should be isolating the small airways. So now you will see reports of R5 and 20 isolating what we call the peripheral airways. Reactance measures the stiffness or the unevenness of ventilation. So it's more negative at the smaller oscillation and becomes neutral and then positive afterwards. AX is the area under the curve of the reactance. These are very important parameters. They measure small airway dysfunction and inhomogeneity of ventilation. So X5, AX, resonant frequency is when the reactance meets 0. So what does that mean? So resistance measures the friction occurring within the airways where there is flow. The reactant measures the stiffness of the lung, it's related to the lung volume, and the inertia of moving gas and tissue into the whole respiratory system. So the expansion of the lung. The resonant frequency, where the X crosses the AX, is where the entire impedance is explained by resistance. I'll show you what happens when a child is sick. And the area under the reactance curve, the AX, measures the stiffness of the lung and the overall heterogeneity of the ventilation. So in the past, we only looked at R5 and 20, as I was saying before, and we probably really underestimated the utility of oscillometry because we were disregarding these measurements that really look more at small airway dysfunction. So let me give you an example. So this is an MRI, ventilation defect on MRI. So you see a person with normal ventilation, and as you see here, patchy area where there's no air. So when there is an increasing ventilation defect, as in here, you can see the curve here, the resistance at the smallest frequency increases. So there's higher resistance at 5 hertz. The reactance becomes more negative. The area of the curve that was quite small becomes quite big. And the resonant frequency, which is where the reactant curves touches 0, becomes higher. So I'll put all that in perspective later, but I just wanted to give you some idea about what these parameters are. So what are the psychometric properties of this? So in 2023, there was a review by the ATS of what should be an ideal clinical test for preschool wheeze. And of course, we need to have commercially available instrument, standard operating procedure, need to be safe, feasible. We need to have adequate population reference value, and within test intra-subject variability measured in small. So all this was okay with oscillometry. What we did not know then, and that's more than 12 years ago, is whether we could distinguish disease population from healthy patients with regards who had, for example, disease that had CF or BPD or recurrent wheeze, and we did not know about the clinical utility, and that's what I want to tackle today. So I started using oscillometry in 1995. I wanted to do studies in the emergency room. I realized that the preschoolers who came in with wheezing and asthma had no.
Madam, you're not audible.
I'm not audible. I'm
Again,
not sure
you
what
are
to do.
audible now. So there are in between breaks. Either
I'm
the
so.
Audio jack is loose or something of that type.
I'm not sure.
Okay, but we can again hear you well.
Yeah.
You're audible now.
Yeah, so sorry. We're at the other side of the planet, so I apologize.
Yes.
So I brought down the oscillometry device in the emergency room, and I tested children that were acutely ill and untrained. That oscillatory device measured resistance at 8 hertz, 16 hertz, and I did spirometry. So you can see that the 3 years old, untrained, acutely ill, 20% were able to do it. 4 years old, 40%, 5 years old, 80%. And then that was maintained 80, 85% in the older ones. It was a little harder to do resistance at 16, but what's most important is spirometry was almost impossible to do in the little ones, less than 20%. And as you well know, it's also hard to do spirometry. About 40% of patients acutely ill will not be able to reproducibly cooperate with spirometry in the acute care setting. So about 60% were able to do it, about 80% of the older children. So we knew it was feasible. I verified the reproducibility, and the coefficient of variation was way below 15%. So we were happy. The intra-class correlation, measuring whether the 2 measurements or 3 measurements measure the same thing, was very good. And then we looked for responsiveness to change. So we measured oscillometry and spirometry before treatment and after bronchodilation in the emergency room. And this is the responsiveness index. The highest is the best. So for the change in percent predicted FEV1, we had a high responsiveness index of 2. And so did, and not very much for peak flow, surprisingly, and so did resistance. Resistance at the smallest frequency was 2.3, so it's very good, at least equal, if not superior, to spirometry. And then we looked to say, well, what would be a 12% change in FEV1? And that corresponded to a 9% decrease in resistance at 8 Hertz. So we did a study that was the first study that we published in 1998. We were testing whether we should give to children with mild and moderate asthma repeated salbutamol, like half the dose every hour versus 1 dose every hour. And there was no difference. And we tested ipratropium, there was no difference. But you can see that as we start treatment with salbutamol, there's a great improvement rapidly. So it's quite responsive to change. It seems like placebo did better. There was almost no children left in the study because they had all been sent home. So this is not significant. So then we went out and did reference values on that instrument. It was called the Custavit R. So we did reference value for our children. We did reference value a few years later with the iOS, what we call the Jaeger. So we published that one. And then just recently, 3 years ago, we did reference value for both the Tremoflow and the Respinar Pro. And what I wanted to show you, the Tremoflow are the little orange dot, and the blue one are the Respinar. And as you can see, the orange dots are higher. So the Tremoflow consistently measure a little higher value for the same child than a Respinar. And same thing with the reactance. So the Tremoflow will measure a little more negative reactance than the Respinar. So that's important because the impact of that is that we cannot use the same reference value, one reference value for the Tremoflow and then use the same one for Respinar. They're not the same. And that has been shown in the lab as well. So this is a colleague of mine in Canada. What he did is he took the 5 instruments that he had and applied some test charge. So this is going to be like 0.2 kilopascal per liter. This one is 0.81. And as you can see, the values change a little bit, but particularly starting around 1 kilopascal, there's quite a big difference. You see the Respinar in blue, it's lower than some of the others. So the Respinar sort of measures a little smaller than the other ones. So all this to say that device don't measure the same value in the same child. And it is more important the smaller the child is, because that's when the resistance is higher, or the sicker the child is. So the message is that different instruments in the same child do not measure the same value. I was part of the team, the Global Initiative for Asthma, where we wanted to create one big reference value using all instruments. We were unable to combine that because there were so much variation between devices and also within the same device between sites. So we're writing a paper to explain that. So the message to you is you have to use the same device to follow the same child, and you have to use the same reference value, the reference value designed for that device in the same patient. So let's look at the scientific evidence for the use of oscillometry in a diagnosis of asthma. So as you well know, for asthma, we need to show obstruction, reversibility, post-bronchodilation or post-treatment with a controller medication. And failing that, we need to go to provocation testing. So can we distinguish between acute and stable asthmatic? And we can. So the most sensitive parameter, discriminative parameter, I should say, is the AX. You see the area under the curve is 0.84. 1 is perfect. P-value is very high. The second one is R520. These are 2 parameters that measure small airway dysfunction. The next one is FEV1 FVC ratio, and to a less degree, the MMEF. And then the last one is R5, which measures the resistance over the entire respiratory system, including the small airways. So how do we interpret this? As you well know, This is the Gauss curve for lung function. We don't care if the patient have better lung function than expected. We care if they have lower lung function. So everybody, like, so this is a normal curve. So the value that the threshold that separates 95% of the normal people from 5% is what we call the upper limit of normal. It's a Z-score of 1.645. So the upper limit of normal applies to parameters where the highest is the worst, that is resistance, AX, and resonant frequency. Conversely, the lower limit of normal applies in parameters where the lowest is the worst. So as we well know, FEV1, FVC, FEV1, FVC ratio, as well in oscillometry as reactance. So the same way as in spirometry, the criteria is if you have an FVC above the lower limit of normal, but your ratio FEV1 FVC is less than a lower limit of normal, you have obstruction. And then you look at your FEV1 to decide whether the child has mild, moderate, or severe. These are the latest criteria from the GLI 2022. They were designed for adults because adults that had Z-score less than 4 had higher morbidity. We don't quite know what the cutoff should be for pediatrics, so we haven't changed for pediatrics. For oscillometry, clearly to identify obstruction, if you don't have personal best, then you are going to look at the Z-score. So the same thing, if the Z-score is above 1.645 for resistance, AX, or resonant frequency, where the highest is the worst, this child has obstruction. If the reactance is below, it's more negative than expected, then this is obstruction. What we don't know is which is the best parameter to identify obstruction. We've always used resistance. We will continue to use resistance, but which parameter do we prioritize if there's a discordance between, for example, reactance and AX? What should be the threshold for severity of obstructions once we've met this cutoff? So it's not clear what we've been using. So it's not clear, but what we've been using is if the Z-score is between 1.64 and 196, which identify 2.5% of the population. If it's between 1.96 and 3 identifies 0.1% of the normal population, would be moderate, and severe would be more. This is likely to change. This may vary between setting. There are no data right now, and we're doing a study right now to try to identify that. What's the recommended cutoff for bronchodilation response? So the cutoff for significant reversibility, pre and post bronchodilation, is based on normal children, and it's based on their 95% upper limit of confidence. So for preschoolers, if you're measuring your resistance at 4, 5, or 6 hertz, usually it's minus 40 to 50. If you're measuring reactance at the small frequency, it's more than 40 or 60, and then reactance if there's a decrease by more than 80. And school aids are a little different. And so overall, the recommendation by the ERS ETS statement, it's ERS, pardon me, in 2000 was that if you have a decrease of resistance at the lower frequency by 40% or more, or an increase in reactance by 50% or more, or a decrease in AX by more than 80%, you can call this significant reversibility. The problem is that this is very, very specific, and it's not sensitive. So we don't quite know if you've made the diagnosis of asthma and we're following the child and we're looking between 2 visits, what is a significant change from the previous visit? It's not quite clear. There's imprecision because there's discordance between the instrument. We don't exactly know what should be the reproducibility coefficient for reactance in AX. We always talk about a CV of less than 15% for resistance, but not for reactance in AX. So sometimes there's more imprecision there. So we're writing a paper right now on this to provide guidance. And then, we're using relative change. Perhaps we should use Z-score. It's not quite clear. What I've been using was a 25% change in resistance at a lower frequency between visits. So you must be wondering, like, there's so many uncertainty, like why would we use oscillometry? You're right, but the same thing also applies to spirometry. We've been using 12% change in FEV1 forever, right? And now in the past few years, we've been talking about a 10% change in FEV1, with the denominator not being the pre-value, but being the value that what should have been predicted for that patient. So that's more and more recommending in adults. We don't quite know in children whether that would apply. There's old studies showing that, 8 to 10% probably is the best. So all this to say that with lung function testing, things are moving both for spirometry and oscillometry. In oscillometry, as I said before, 40% R5 or 80% more increase in X5 or an 80% or more decrease in AX, any one of them. That's based on the upper limit of normal. As I said before, they're highly specific to confirm asthma, and I will show you the data, but they're very poorly sensitive to exclude the diagnosis of asthma. So 0 to 30%, which means that if you do the test and you apply this cutoff, if the patient met the threshold, you're really sure that the child has asthma. The number of false positive is very, 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 very small. But if they don't meet the cutoff, the majority of your patients that have asthma will not meet this cutoff because they're very stringent. So we set out to revise that. So this paper has been presented at ERS in 2025. It's been submitted for publication, so it may not be the last version, but let me just show you. So people have used 28% with specificity, sensitivity around 80. Other identify 11% change, not 40, but 28, 11% with poor specificity. Others 34% with high specificity. So what we did is we created a regression model. And if you're using the cutoff that was recommended by King, which is here, the sensitivity is 0. The specificity is 99%. So what we are proposing, it has not been endorsed by guidelines, but what we're proposing is maybe the optimal threshold, the one that will maximize both sensitivity and specificity, should be more around 17%. We had found 18% in our study in the emergency room. If you really want to make sure that you don't misdiagnose patient and you want the highest specificity, then a threshold around 38% would be the one. So the BDR thresholds for oscillometry are likely to change because the current ones are too stringent. You will have to go to methylcholine testing in almost everybody to prove the diagnosis. What about provocation testing? So in the ERS statement 2000, with regards to cutoff, they said, look, the variability is so wide. The cutoff seems to depend on the method and the study population. We recommend that local thresholds be developed by laboratory and equipment. So that's not quite useful because it's a lot of work to do that. But usually 45% or 50% increase in resistance at the lowest frequency correspond to a 20% decrease in FEV1. And among all the criteria, the resistance NAX seems to be even more sensitive than FEV1. Let me show you. So this is, again, the systematic review that I'm talking about that's been submitted for publication. So some people have thought that a cutoff was for identifying a 20% drop was about 50% change in resistance, 45% increase in resistance, 45% or 22%. So again, what we did is we did a regression model and we plotted everybody. So the sensitivity, depending on the cutoff you choose, varies between about 15 to 85%. That means people that have really asthma, about between 15 and 85% will be diagnosed, depending on what the cutoff is. The specificity varies between 71 and 87%. The optimal threshold, the one that will maximize sensitivity and specificity, so about 74% both, would be around 28. If you want to have maximum specificity, like 95, your threshold has to go as high as 68. So it's really down here. And what we've been using for a long time is around 40, 45. So it's not clear. If your goal is not to mislabel someone as being asthmatic, a more stringent cutoff is best. If you don't want to miss someone having asthma and say this is not asthma, then you need to lower the cutoff. So we hope that this will give guidelines to the next ERS statement. So they're going to be proposed. And just to give you an idea, this is a study that was done where we did at the same time oscillometry and FEV1 during a provocation testing with methacholine. And you see the increase here in resistance, you see the decrease in FEV1. Let me just go back. So the proposed cutoff from that study was 45. And what they noticed is that the methacholine dose to reach a PC20 was 0.48, but it was actually much lower for oscillometry to meet the 45% increase. So it's a shorter task when you do oscillometry. The problem with all this is that our gold standard is always spirometry, and oscillometry is more sensitive than spirometry. So that confounds a little bit the issues when we're trying to compare with something that's less sensitive than oscillometry. So for the diagnosis, how can we use oscillometry? Well, in lieu of spirometry, if spirometry is not available or it's not feasible, particularly in preschoolers or older children in the office setting or elderly people who have trouble with cooperation. With regards to the diagnosis, to measure airway resistance versus reference value, there is no problem. Reversibility, the cutoffs, the cutoffs will change. Right now, they're quite stringent. And to measure airway hyperreactivity, the majority of us have been using 45, 50% for a while. They may change. So you might be thinking, this is a moving target. Yes, it is a moving target. And the recommended threshold and parameters in which to judge reversibility and airway hyperreactivity may change in the near future. What about risk assessment? So can we predict by measuring lung function today what will happen at the next visit? So this is a group of children age 7 to 17 who are well controlled at baseline. This is visit 1 at baseline. And at the visit 2, 30% had lost control. So this is the value of both groups at V1. This is control, remain control. This is control and lost control at the next visit. But we're at the visit 1. And these are the spirometry parameters. And you can see there's no difference between the two groups in FEV1, FVC. There is a significant difference in FEV1, FVC ratio, but in the group that will lose control, the FEV1, FVC ratio is way within normal limits. It's not abnormal. And there is, So if you go at the visit 2 and see what happened, then there's a trend towards a FEV1 a little lower and all that. And you can see the FEV1 FVC having dropped here. So clearly FEV1 FVC could predict a future loss of lung function. But usually it's within normal limits. So you have to follow FEV1 FVC and say, it's dropping from the previous visit. So maybe I should be concerned. What about oscillometry? So this is the same study. The results are reported more graphically here. So again, this is people that had remained controlled at the 2 visit. These are kids that were controlled at the first visit and lost control at the next visit. And you can see for resistance at 5 Hertz, it's a significant group difference at the visit 1. There's a significant group difference in R5 and R20 at visit 1. There's a significant group difference at AX at visit 1. So all these parameters measure small airway dysfunction. These are the ones that are difficult to measure with spirometry. So one of my colleagues, Stan Galland, decided to do like a score for small airway dysfunction. And what he observed in his population, he separated his population into those that were normal in green, those that were abnormal, so above 1.64, so above the 95th percentile for age and sex, And then those that were more abnormal, that were in the 2% 2 percentile of the upper limit of normal. So resistance at 5 hertz, 30%, about 27% of people that have normal resistance at 5 hertz today are likely to lose control or to have an uncontrolled visit at the next time. 33% for those that are already abnormal at visit 1 will lose control, and 59% of those that have a resistance above the 99.7 percentile will lose control at the next visit. So you see the same thing for R520. This is for AX, and the thing that is the one that's more sensitive is reactance. Reactance at 5 hertz, 0.3 if you're normal. Those that were above normal were 50%, so 1 chance in 2, and then 80% chance of having an exacerbation if you were the upper 97.5 percentile. So he created this score. He said the child was going to be deemed to have small airway dysfunction if the Z-score at Z5 or at R5 or R520 or AX is above the upper limit of normal, or the Z-score of X5 is below the lower limit of normal. And he looked at this score, and for patients that were well controlled, about 30% met at least one criteria for per control. So that means that a lot of our patients that we see, that we identify as well controlled, if you do oscillometry, these patients do have small airway dysfunction. Of course, this goes even higher. It's almost 2/3 of patients that are uncontrolled have small airway dysfunction. So small airway dysfunction in about 1/3 of seemingly well-controlled patients and 2/3 of poorly controlled patients. The same thing was shown in the large Atlantic study that was published in adult. So small airway dysfunction, we're referring always to bronchi that are less than 2 millimeter. So their score was based on R520, X5, and AX. They separated the patients into tertile, and whenever you move from one tertile to the other, you gain a point. So you had a maximum of 0, a minimum of 0, maximum of 12. And what they did is they follow their patients, they measure the SAD score at baseline, and they follow these adults for 12 months. And what they saw was that this ordinal score predicted the risk of exacerbation in the next 12 months. For every 1 point increase in the SAD score, it increased by 16% the risk of exacerbation after adjustment for everything else, number of prior exacerbation, the GNS step, eosinophil, and FEV1. The SAD score correlated with the asthma control test, and they suggested that SAD, small airway dysfunction, could be considered as a treatable trait. For example, using molecules that are small molecules that better reach the small airways, like cyclizonide, for example. What about monitoring? So what we did is we had been using oscillometry in our clinic for a while, and we just looked at the data retrospectively. So it was a cross-sectional study with a nested retrospective cohort. These were children that were aged between 3 and 5 years. They had asthma. They were followed the asthma clinic of 2 hospitals. So my first hospital, and then I moved to the other one. So between 2002 and 2018. It's based on the extensive asthma clinic database. And the patients were identified as being exposed if they had visits with oscillometry, or not exposed if they had no oscillometry at the visit. And these kids were batched by propensity score to mimic a randomized control trial. What did we see? So the first thing we wanted to know is, when we measure oscillometry today, does it change our perception that the child has a persistent asthma phenotype? And the answer is yes. Like, we increase the likelihood that we're going to call this child today as having persistent asthma by more than 2-fold. And that's not quite surprising, because you see the child, he looks okay, the exam is okay, the history is it's not worrisome. But then you look at the lung function test and say, oh my God, the resistance is really elevated. So this child does have persistent asthma, even if I don't realize it. So the persistent phenotype was increased. It has a trend towards increasing the maintenance treatment prescription, but not that much. And that's probably because the majority of kids, as you well know, are not very adherent to treatment. So we probably use this opportunity to say, look, your resistance is elevated. You have to take your medication and talk about this. What happened in the next 12 months following that visit? So patients that were followed by oscillometry had a reduced likelihood of not losing asthma control by 76%. In other words, if you were followed by oscillometry, the child was followed by oscillometry, the likelihood of having a poor asthma control in the next 12 months really decreased dramatically. There was some effect of the site. So there was one site where there was people were more out of control. The most interesting is this one, and let me show you what that is. So if the child had been out of control in the next 6 months prior to the study, here you have one hospital, the other hospital. If they had been out of control in the past 6 months, which means they ended up in the emergency room for asthma or had rescue oral steroids or were hospitalized for asthma, and if they were not tested, they did not have oscillometry or tested, it didn't change anything. These children are at very high risk of recurring. As you know, the most important factor to predict having an admission, having an exacerbation in the next 12 months is having had one in it. So really, oscillometry did not help if the child was evidently not well controlled. But if the child had been controlled in the past 6 months, so no emergency visits, no rescue oral steroids, no hospital admission, if they were untested, for this hospital, they had about 50% chance of being not well controlled in the next 12 months, but that went down by almost 2/3, down to 18%. And the same thing here, from 26 to 7.8%. Conversely, the likelihood of being well controlled increased dramatically if the child had been well controlled in the past 6 months and was tested with oscillometry. So why did that happen? Well, it happened because we identified bronchial obstruction that was unsuspected by medical history and physical exam. So that's the contribution of oscillometry. If the child looks good, you do the oscillometry, it is abnormal, then you can act upon it. What are the key messages? Oscillometry is discriminative to distinguish between sick and healthy population, to distinguish across severity and control level. Lung function deterioration. And in preschoolers, adding oscillometry to your clinical judgment is associated with better asthma control in the next 12 months. So compared to spirometry, oscillometry is more sensitive to detecting peripheral obstructions or small airway dysfunction. So if you have a child that has normal spirometry, but the child has ongoing symptoms of asthma or reduced asthma control, if you do oscillometry, you're probably going to be able to identify that the child has small airway dysfunction. It's better to predict the risk of exacerbation and predict the loss of asthma control. So many of my colleagues are using both spirometry and oscillometry in older kids. Challenge is negative with spirometry, despite suggestive symptoms, including symptoms that occur during testing, then you might want to consider repeating the methacholine with oscillometry. So let's finalize the challenges and facilitators. So with regards to barriers, what's the issue with oscillometry? Well, we have a lack of awareness of oscillometry as lung function. If you ask around, a lot of people don't know what oscillometry is. A lot of physicians don't know. A lot of respirologists don't know. We are unfamiliar with the oscillometry mechanics. We haven't learned that in medical school. We need expertise to interpret these, particularly in light of the number of parameters. And they are significant between instrument measurement difference. We have expectation of clarification of a bronchodilation response, provocation, and severity threshold. We should and can use the one that are currently published, but we know that we're probably very too specific. And the other thing that's the issue is that there's no or limited recommendation for use of oscillometry in guidelines, and that impedes reimbursement and uptake. So in the GNAT 2025, we've added something. Oh, I think it's the next slide, but we've added something to that. What are the facilitators? The devices are available in all 5 continents around the world. For the child, just breathing at tidal breathing is easier. It's easy for children, for elderly, for severe acute asthma. It's rapid. It takes 16 to 30 seconds to get one measurement. You will need 3. So, within 5 minutes, you'll be done. There are normative data in different populations. There's no apparent impact of ethnicity. We have a very multi-ethnic population in Canada, and we looked for differences with ethnicity. We did not find any. There are parameters that maybe are being examined now for being less subject to between device variations, such as the ratio between R520 and R5, but we don't quite know yet, and there will be regular updates of interpretation standards. So oscillometry is an evolving area of research. This is the number of publications in the past 25, 30 years for adults, children, and in total. And then you can see there's been a tremendous increase in the past 7 years. So what's next? For guidelines perspective, there were arguments for not recommending oscillometry until we had a randomized control trial that demonstrated the superiority of oscillometry over nose spirometry, or RCT to demonstrate the non-inferiority of oscillometry versus spirometry. But these arguments do not hold when between 9 and 49% of children with asthma and up to 70% of adults with asthma or COPD remain undiagnosed. And their lack of diagnosis had significant health burden on these patients. And we know that if we were to diagnose them early and manage them early, we will have a favorable impact on health outcome. So the argument to still wait does not hold. So oscillometry is a valid substitute for and in addition to spirometry. So in the GINA 2005, we added this paragraph: alternative measure for lung function testing, including oscillometry and provocation challenge testing, are available for children as young as 3 years old. Oscillometry is a non-invasive, effort-independent lung function test obtained during quiet tidal breathing, which can be performed in children as young as 3 and can be used to assess bronchodilator responsiveness. Oscillometry measurements differ between devices, so device-specific reference values should be used. So I just wanted to close, if I have a few minutes, on 2 cases, just to give you an idea of how do we interpret that. So this is a 6-year-old child. You see the predicted value for his age and height, 1.05. This is the lower limit of normal. We're concerned about the upper limit of normal because that's resistance. He had 132 instead of 105. That represents 126% predicted, and the Z-score is 1.86. That's above 1.645. So this child has obstruction based on resistance at 5 Hertz. If you look at resistance at 20 Hertz, we're supposed to have 0.75. He has 1.02. That represents a percent predictor of 135, a Z-score of 2.14. This is the above 2.5 percentile of normal population. This is obstruction. There's no obstruction in X5, and then you can see the Z-score for AX is normal as well. So the child has mild overall, because resistance measure the overall respiratory system, as well as central obstruction. There's no obstacle to pulmonary expansion, X5, like if he was obese, for example. There's no ventilation inhomogeneity, the AX is normal, and there's no BDR, so it hasn't been tested. Here's one where the BDR has been tested. So it's a 5-year-old boy. Again, the value was supposed to be 1. He had 1.3. That's 132. A Z-score of 2.22. So just to remind you, above 1.645, it identified 5% normal population. 196, 2.5%. So he's above 2.5%. Resistance at 20 Hertz within normal limits, less than 1.64. Reactance within normal limits. The AX is the upper limit of normal is 5.25. He's 6.06, so the Z-score is 2.3. So he's above the upper limit of normal. What happens post-BD? So there's no significant change between, so -9, we're talking about we should have something like 40%, so we don't have 40% here. No change for R20. There's no change for IX, it has to be 80%, but look at this, there's a significant change for reactance. He was within normal limits, 0.42, but he could go much, much lower, 0.01. So that's 96.8% decrease. So this child has moderate overall obstruction, probably mostly peripheral, because his Z-score is mostly at R5, that abnormal. He has heterogeneity of the ventilation distribution by the AX. And there's significant reversibility in X5, which is above -50 here. But he did not meet the cutoff for reversibility with resistance. He did not meet -40. And for AX, he didn't meet 80. But it's any one of these three. So we would call this child with moderate obstruction and bronchodilator reversibility. So the key messages to close. Clinical utility in US spirometry, if you cannot do spirometry, if it's unavailable, not feasible. In addition to spirometry for suspected symptoms, for the diagnosis clearly to identify airway obstruction, reversibility post-BD or between visits, and airway hyperreactivity, although we know the cutoffs will probably change. It's useful to monitor patients over time and look at within patient change as a result of treatment adjustment using the personal best value, and it's more sensitive to small airway obstruction than spirometry. It's useful for phenotype assessment, so we can think that the child is normal, but the lung function may tell us otherwise, and acting upon that it will improve lung function, asthma control. So recommendation for clinical application, we have to measure lung function, mostly, but not only when the child is per control. Choose your instrument. There's a variety of instruments. The ones that we've been working on with are here, but there might be others that I don't know. Because of the discordance in value measured on different instruments, use instrument and frequency-specific reference value. So there are international values, there's Canadian values, but just make sure that you keep the same reference value within patient. Use the upper limit of normal or the lower limit of normal, depending on the parameter, or the personal best to determine obstruction. We need to use the approved cutoff for BDR for diagnosis, acknowledging their very poor sensitivity and very high specificity. So we know that using this cutoff, we will have to do more metacholine challenge for sure. The cutoff I've already enunciated. You can consider instead using 17% decrease in resistance for BDR. That will give you optimal sensitivity and specificity, at least in known asthmatic when you're following the child between visits. But you might identify more reversibility than they really are. And then you can consider 45% increase in resistance. That's the majority of us are doing, acknowledging that it has a fair sensitivity and a very high specificity. If you want to read a little bit more about this, I just published a year ago a review on oscillometry and a diagnosis, assessment, and monitoring of asthma in children. You're welcome to look it up. And I'm just going to close on my favorite sport, which is helicopter skiing. And I'm going there in 2 weeks. So thank you very much for your attention.
Thank you so much, ma'am, for a very, very nice and lucid presentation. So we had a very, you have dealt with this subject meticulously, and you have covered almost every aspect of this. Sarah, there are a few questions in the chat box. The first is, which parameter is more sensitive to bronchodilator reversibility? I think your last slide has given this. 17% is what you say. That when you look at bronchodilator, when it comes to diagnosing this 1.64, 40, 50, and 80, this is what you said. But when it comes to bronchodilator reversibility, I think 17% is what you said.
Well, the question was about the parameter, and it's a very good question. As we said before, we've been focused on resistance all along. But in the example that I gave you, resistance was not reversible, but the reactance was reversible. So I think we need to look at all four parameters: the AX, the resistance, the reactance, and I'm missing one. Yeah.
Okay.
But yeah, we need to look at other.
If I put the question as it is, which parameter is more sensitive for bronchodilator reversibility? I think the way you show that the logistic regressions, I think based on that, 17% is the one where you will have the best sensitivity and specificity for bronchodilator
So that's the best.
reversibility.
It's the best cutoff. You're right, but we
Yes.
only looked at resistance because we could not do a regression model for reactance or AX,
Okay.
so I cannot respond to answer the question. We don't have the data. The data had not been published, and it was impossible to do a systematic review. So we don't quite know, and I think we need to keep our eyes open and use all parameters for BDR.
Perfect, ma'am. The another question is why sometimes we do not get AX in small children?
To have AX, you need to have multiple oscillation frequencies. So if you're doing, for example, the Respinar Pro for little ones, you can do it on at 8 hertz. It's a single frequency. So you will not have an area under the curve because you don't have higher frequency than that. So that's reason number one. Reason number two, it depends if the device that you have had the AX reference values for AX. So we created it for Tremoflow and Respinar. There are some for other device, but you need to look for reference value that reflects your population and has AX. Otherwise, it will not report it.
Okay. And what about bronchodilator reversibility in resonant frequency? So I think you said other than resistance at 5, you do not have enough evidence for the rest.
So what I said is that we could not propose a different cutoff for reactance and AX and resonant frequency because in the studies, as I said before, people were only focused on R5 and R10, a few X. So almost nobody published that. So going forward, we are asking people to look at all this, publish their data, do the metacholine challenge with spirometry and oscillometry using all parameters, report all parameters so that we can know. But right now we don't know because the data has not been published.
I think that's the answer, that R5 is something for which we have data. The rest is still unanswered. Experts are welcome to add to the literature here. So I think it was a good talk. Now let me put it in more simpler words. If you have the option of using, say it's a 4-year-old child, using spirometry alone, IUS alone, or a combination, first time to make a diagnosis, which one would you pick up?
How old is a child? 4 years old?
In a 4-year child, in a 4-year-old child, you have spirometry alone, you have IUS alone, or you have a combination. Which one will you choose?
Unless I have an exceptional technician and an exceptional child, the spirometry will not work. I'll go with oscillometry, definitely. Yes, I mean, it is more sensitive as well. It's really more sensitive than spirometry. We don't have this leisure here in Canada to do 2 lung function tests always because of limitation with respiratory technicians and all this. But some of my colleagues in the US and in Mexico, they are systematically doing oscillometry and spirometry in children old enough to have both because it gives them a different perspective on the lung mechanics.
Okay, fine. So the question that I asked was regarding the validity of this test. When we say we do not have normograms, so when you are doing a test for the first time in a child to make a diagnosis of asthma, at that time, given the lack of literature in terms of normograms, would you think that IUS alone would help you in making a diagnosis? Or it will be a better tool to maybe monitor him over time? But when it comes to first-time diagnosis, without a spirometry, you would be comfortable with IUS?
With oscillometry, absolutely. When we talk normogram is reference values. So there's reference values for, for determining whether the child has obstruction or not. So this is well established. There's no issue with that. There's no question. We can definitely realize that the patient is above or below the lower limit of normal. If you're talking about BDR, the recommendation is to use the ERS statement, knowing that the majority of the true asthmatic will not meet these criteria, and you will have to move on to provocation testing.
Fine, ma'am.
Yeah.
Okay, if we are in a habit of looking at spirometry graphs, and based on graphs, we can say, okay, this was not done appropriately, this was not done right. So is there a way to look at the graphs of an IUS and say, this was not done appropriately?
Yeah, thank you so much. I wanted to put graph and I thought, oh, this presentation is going to be quite long. Maybe I should cut it. So I did not put, but yes, it's not only the graph, it's really as the data, during the data acquisition, if we look at the sinusoidal wave, and if the child swallows or coughs or vocalize in any way, or there's a leak, you will see it right away. So in the past, the technician needed to physically remove that breath and consider the other one. The internal validity of the new instruments are really, really good. They're not perfect, but they're really, really good. But yes, it's really at data acquisition that you will see. But when you see the graphs, you might see, 2-3 repeated measures that are really, really close together, and then one that's completely off. So that's problematic. That off, then you need to open up the software and see how did this child breathe. It takes a little longer to do it, but we can do that. We're actually reviewing over 1,000 curves right now, and we're trying to find a way to automate that so that we don't need to rely on having to do all this. But anyway, but yeah, there's a way of looking at it and identifying that something seems fishy.
Perfect. So we know spirometry, as we see, it's a device which primarily looks at obstruction. If FVC is low, we may say there might be a restriction there. So when it comes to IUS, I think Satya Srivastav is asking this question, that if you look at IUS, will it be able to pick up restrictive lung disease too?
It's a very good question, and I'm not sure the answer to that. I can tell you what I've used oscillometry for, in addition to asthma, is patients that had asthma and vocal cord dysfunction. And so you did spirometry, and each time, because it was a forced maneuver, the child would block the glottis, and then you would have terrible lung function that were completely disproportionate to the way the child looked. And then when you do oscillometry, then you don't have that. There's no forced oscillation. So you can do that. If there's a lot of restriction, let's say imposed by someone who's obese, for example, then your AX and your reactance is going to increase dramatically, and not so much your resistance. So the resistance is really to the flow passage, and the reactance is really to the expansion of the lungs. So
my question was more, I think I need to reframe my question. My question was about a child who is supposed interstitial lung disease. Here, the residual lung volume is less.
Yep.
They may not have any obstruction. So in such a child where there is no obstruction, primarily restriction, like we would ideally do a DLC on such a patient. So will IUS help?
So I lost the words now, but
okay, I'll repeat it. In a restricted lung disease.
I get that. So I think I'm not sure that how I can answer that, because I focus on asthma, but they were unable to. Yeah, I'm not sure. It's a good question. I cannot answer that question.
Because I believe restrictive lung disease is somewhere you have a reduction in the residual lung volume, and it is only DLC probably which can pick it up. IUS, like spirometer, can only tell us that when you breathe out or breathe in, how much is the resistance or reactance, all that thing. But how much is there inside? Difficult. Okay, ma'am. There is a question again from Satya. Like we have different things in mind. For example, bronchiolitis obliterans. Like in small airway diseases like bronchiolitis obliterans, where BD is not seen or is variable. Or any idea, light on this topic about bronchiolitis obliterans? Any studies on bronchiolitis obliterans with IUS, in other words?
I am not sure. I'm not sure.
So because this is a very small niche or patient group that we have, and it has a fixed kind of an obstruction. Okay, Doctor. Now we have Dr. Krishna coming up, and he is asking, what may be the reason for differences in R5, AX, and X5 values in the same child who have peripheral airway disease? Example, R5 may be elevated, but the other two are normal. Or X5 is more negative and the other two parameters are normal.
Yeah, so the resistance measures the resistance measure the friction into the bronchi. The reactance is really the expansion. So it's really it's not within, it's outside. And the AX is of course the inhomogeneity of the the bronchi. So you may have someone that has not so much small airway dysfunction, but really more difficulty in expansion. You often will find them together, to be honest. You can have more inhomogeneity of the ventilation with the AX being quite high and the resistance not so elevated. We are going to learn more and more about whether these are distinct phenotype. As I said, this is really, there's an explosion right now of studies on oscillometry in different conditions. So we will learn more about that, but they're measuring different things.
Any personal experience or any literature about oscillometry in intubated children?
In individual children?
In intubated children who have been intubated.
So I'm a
Endotracheal
pediatrician,
intubation.
right? I'm a pediatrician. I'm not an intensivist. I know they are because it's been used. They have an adaptation for patients that are intubated to be able to measure resistance there. So definitely they have been. It's been done. There's some studies about that, but I'm not knowledgeable to be able to answer that question.
Perfect, man. Dr. Samir Bide is asking that on follow-up in asthma patients, which parameter is more important to see for improvement in lung function?
Which parameter
would be more important or relevant when it comes to monitoring lung function in a child who with asthma? I think we lost your audio, ma'am.
He has probably lost connection or what?
Sorry, I got disconnected. I'm back.
Yes, you're back with a bang.
I'm so sorry.
So it's a very inquisitive audience, I believe. So if a child is like we talked about the initial diagnosis of an asthma, now we are talking about a child who has been diagnosed with asthma, and you are trying to monitor this child. So during follow-up of a child with asthma, which parameter is more important?
The one that we follow the most is the resistance at the small oscillation frequencies, so R5 or I7, depending on the instrument you have. But we look at the other ones. What you will see, because asthma is mostly you're going to usually your resistance will increase before the other parameter, but not always. So we follow that. It's easy to explain to parents as well. Oh, the resistance inside the bronchi has increased. Look, the number is that way. I use it a lot when I see patients the same way with spirometry. I say, that's funny. The lung function is worse than before. I turn around to examine the child, and in my bag, then the parents say, well, maybe I stopped the medication 2 months ago. And so it's very useful as for spirometry for biofeedback. But usually it's resistance. Why is it mostly resistance? I think we've been using resistance only, as I said before, like for the past 30 years. So it's the first thing that we go through. Is it correct? Should we systematically look at other stuff? But a lot of data has been on resistance, so that's why we're using it right now. But I think that may change in the future.
Perfect, ma'am. Dr. Anil Sachdev, he is the head of the intensive care in Gangaram Hospital, Delhi. Can ERS or a similar body ask the manufacturers to use same kind of frequencies so as to mitigate the difference between performance and the result? Do you think it would work?
To use the same frequencies?
Yes.
I would, absolutely.
Okay. So can ERS or as a body, somebody can take this up?
Well, I'm not responsible for this, but I know there's going to be, well, you can ask for a new position, but usually the way it works is that you have to propose that you want to do it, and then you get money from them. So if he wants to do it, go for it. We need more people working on this.
Okay, so an easy question. Is R5 better or R5 minus 20 better for the diagnosis of asthma?
For the diagnosis, I'm not sure what's better. As I said, all the data, most of the data is on R5, but more and more we realize that R520 is even more sensitive. I would recommend, if you're using oscillometry, ask for the report to indicate the R520. A lot of the reference values did not propose this, does not have reference value for that. So ours do, and others may as well. So select a device and reference value that has that and follow it up. The problem is, I sense the majority, the body of the publication is on resistance, very little on the other ones. But we are keeping a close eye on that, and we see patients that don't seem to have very much obstruction other than R520.
So, Professor Francine, one question which I have not been able to understand, I'll just read it out verbatim. In your experience, quick I-12 COSMED working status in a given child. I don't know what's quick I-12 COSMED. It's there in the question.
COSMED is a device. I'm trying to see if I can see what was... No, I don't see the question in the chat.
Then ask the person to unmute and ask, sir. You can ask the person to unmute and ask.
Dr. Krishna, are you there? Okay, I think he may not have the panel link.
Okay.
So fine, let's move on to the question. In ILD only reactants will be low. There is a comment rather. In ILD only reactants will be low with normal R5 and no response to bronchodilator.
Yep.
Okay. Perfect, ma'am. So as I would say, somebody has said that physics is the art of measurement. And I think this machine does measure well. It is very sensitive. And what it stands apart is the ability to conduct tests in a child who would not have otherwise not been able to do a expiratory maneuver. So in that sense, it's a good beginning. But I think we are still fumbling to get those normative values where in all settings, in every place, we can use that cutoff and make a diagnosis. So as a reliable tool, yes, it is reliable. Repeat measurements will be the same, but in terms of validity in a setting, I think it still needs to work on. For example, in our country, we do not have a normative data. So if you do it for the first time for the diagnosis in a patient, then in an individual patient, it throws up a challenge. But in a research setting, it does.
Yeah. I disagree with this because with regards to obstruction, there are normative value. There are normative value for all devices. So you can definitely identify obstruction. There are normative value for BDR. I'm just warning you that they're very specific and not very sensitive. And these normative value will change. I mean, the recommendation of 40%, 50, 80%, they will like this. So the reference are there. I found it very useful. I've been using it, as I said, since 1996, originally in research and then in clinical practice. It allows you, because we're talking about obstruction based on reference value, for example, but the same way as for spirometry, you will follow the child based on a personal best.
Yes,
sometimes the personal best, it's much higher. We have some people with FEV1 of 130% of predicted. And when they fall to 90%, we get all excited. But 90% is within normal limits. But for the child, it's significantly lower than expected. So following the child longitudinally it's very useful to use oscillometry if you have access to that. I've only used it originally only in kids that were not able to do spirometry. You can do diagnosis as young as 3, 4, 5. As I said, a lot of my and people that you can do spirometry, older ones, or because of neuromuscular issues or corporation or vocal dysfunction. I don't have very much experience doing it consistently with spirometry. A lot of research are showing that it's more sensitive, and a lot of my colleagues in the US and Mexico are using it systematically. Like it's the same way as you might do pheno and spirometry, they do oscillometry and spirometry. So, but definitely, if you don't have access to spirometry, or you cannot do spirometry in a child, definitely consider that.
So, ma'am, in a country like us, spirometry is much more easily available. It costs much less. So IUS will be a tough nut. So if you wish to get one machine, spirometry is much easier to get. IUS is difficult to get. So, so if suppose if a general pediatrician wants to have a machine, would you recommend IUS for him to use an IUS or no?
No, the gold standard is spirometry. Everybody's been using spirometry. It's
Yes,
been
this
the
is
gold
the word
standard
that we were looking
forever.
for.
Yeah.
This is the word that we're looking
Yeah.
for. Otherwise, you'll be misconstrued. So,
Yeah,
what
yeah,
is the
yeah.
gold standard?
It remains the gold standard.
Absolutely. This is
Yeah,
what I wanted to bring it to.
I totally agree. It remains a gold standard, and it is for us as well. We're using it when the child cannot do it, right?
Yes.
When the child cannot do it.
So
Yeah.
every slide said that if you cannot do spirometry, come to iOS. But otherwise, gold standard remains spirometry. So
I totally agree.
I think this is what we all wanted. I think Dr. Javed, Dr. Rawat sir, how much time do we have?
Yeah, we are already over.
Overtime. So I think we have had a very, very good discussion. From my side, it was a learning 1 hour or so for me. Thank you so much for a very, very nice presentation. Thank you, Professor Francine, from Dr. Kamal this side. And I hand over the proceedings to Dr. Javed Iqbal and Dr. Sanjeev Rawat. Thank you.
A pleasure.
Thank you so much, Doctor. Thank you, Dr. Francine. It was a wonderful presentation. We today really learned a lot. For final comments, we hand over mic to our chairperson.
Thank you, Dr. Francine. It has been incredible to listen to a person who has an experience of 25 years using iOS. Well, your first paper was published in 1997, and it is really great to listen to you. I think all the people who are on board today, they must have got very important insights regarding the use of oscillometry, regarding all the cutoffs, what you have been using, various parameters for obstruction and reversibility. And I think your presentation would stimulate more of the young pulmonologists to use this machine more and more. I think that your statement is that spirometry is the gold standard. That really holds true. And definitely in those places where you cannot do spirometry, like a child who is below 5 years, who is not able to perform. Definitely, and even in your GINA guidelines, you have clearly mentioned that smaller children, because this is a treatable trait, and if you document reversibility, child below 5 years by oscillometry, that is a treatable trait, and you can definitely treat as asthma. I think this thing, what you have told, is really very valuable, and I think this will give a lot of young people across India to start using this machine. Of course, below 5 years as a standalone test to confirm obstruction, and above 5 years, definitely spirometry is the gold standard. And in all difficult cases where you are not able to find out by spirometry, you can definitely do iOS. So, madam, thank you very much. It has been a wonderful session, and we hope to interact more and more with you. In future, we'll invite you for more sessions. We'll learn more from you. Thank you very much. So, till that time, it is. I'd like to thank Dr. Kamal for an excellent moderation, excellent interaction, and of course, Dr. Javed Iqbal. Without his help, this thing would not be possible. So I'd like to thank Dr. Javed also, and all the delegates who have been there till this time for more than 1 hour, and they were interacting very, very actively. Thank you very much. So it is good night and goodbye from IPNRC till we meet again. Thank you very much, madam. Good night to you.
Thank you.
Bye-bye.
Bye-bye.